Assalamu alaikum. Good evening, everyone. We are so happy to host you today for the fourth live transmission by the CEC. This is a webinar focusing on a very important issue in the form of a case-based presentation, how to deal with a patient that is recommended or indicated to take a triple antithrombotic therapy post-intervention. I'm very glad and honored to present Dr. Ahmed Bindari, lecturer of cardiology at Banha University. Ahmed is my personal friend and brother, and he is a very eminent and scientific-based doctor. And he has a very good control and manipulation of the case-based sessions, because I attended several case-based sessions by him previously. It was so interesting and beneficial. I'm greatly honored also to introduce my dear professor and older brother and role model, Professor Karim Saeed, Professor of Cardiology at Cairo University. Professor Karim is one of the most scientific cardiologists in Egypt, actually. And for me, he is my role model regarding this aspect. I respect him so much, and I always learn from his lectures and from his interactions and moderations. I would like to introduce Dr. Karim Mahmoud. He will be managing together with Dr. Haitham Sulaiman the YouTube channel, and all of your interactions on the YouTube will be transmitted to the Zoom meeting here. Dr. Ahmed Saeed is managing the live transmission on the YouTube channel from the technical point of view, and Dr. Abdurrahman Gamal will be joining us here on the platform. I would like to thank you all. And it's time to start the session now by Dr. Ahmed Bindari. You may proceed, Dr. Ahmed.
Thank you, Dr. Zahran, for this introduction. First, Ramadan Kareem to all. Actually, it's very nice to be here today. Hi, everyone. We are going today to discuss a very nice and actually a complex topic in managing patients who have underwent percutaneous coronary intervention or PCI, and at the same time in need of oral anticoagulants for whatever reason, especially non-valvular atrial fibrillation. We elected to present the case in a real case-based CME manner. This is because this type of presentation could give some insights into how could we manage such real patients. Let's start with this case. We have a 51 years old female patient. She is hypertensive for 5 years and with non-insulin dependent diabetes for 6 years. She has a history of right hemiparesis 2 years ago. She has documented atrial fibrillation. She is on warfarin, but with poor time in therapeutic range, or TTR. We all know that the time in therapeutic range is the gold standard for adjudicating how good anticoagulation is using warfarin. In the best case scenario, I think in Sweden, it's about 65% of time. This is to say, if you did 10 INR throughout a year, and about 7 of them are within the target, which is from 2 to 3. This is to say that you have a 70% time in therapeutic range, and so on. She has poor time in therapeutic range, let's say about 50%. Okay. She has chronic coronary syndrome with recurrent chest pain 3 months ago, despite optimal medical therapy. She underwent coronary angiography that revealed a 90% proximal focal LED stenosis with normal other coronaries, for which she went uncomplicated PCI to this lesion with a drug-eluting stent 3.18 millimeters. On examination, the blood pressure was 130/80, the pulse was 70 beats per minute and regular. Note that she has paroxysmal AF, not permanent or persistent AF. The body weight is 82 kilograms, the height is 173. She has unremarkable chest and heart examination. Her routine lab workup reveals that serum creatinine was 0.2 milligram per deciliter. We calculated the estimated GFR. It was 89 milliliter per minute. Her hemoglobin A1C was 7.3, and her INR at time of examination was 1.85. Let's have a pause and hear the comments and wrap up of this clinical data from my elder brother, which I deeply welcome, Dr. Karim Saeed, Professor of Cardiology at Cairo University. Dr. Karim?
Okay, hello everyone. Good night. I'm very happy to be with you today for this interesting topic. Actually, the case we are facing now is not an uncommon one. To have atrial fibrillation combined with coronary artery disease is a common scenario. Actually, about 1/3 of patients with atrial fibrillation do have underlying coronary artery disease. And up to 20% of patients with acute coronary syndrome do have atrial fibrillation upon presentation. The problem here we are encountering in this case, we should give multiple antithrombotic. We should give anticoagulant for the atrial fibrillation, and we should give antiplatelet for the ischemia, and antiplatelet for the recent PCI. If we give these excess antithrombotic agents, we are expecting more risk of bleeding. And as you know, more risk of bleeding is associated with more risk of mortality. So we have to make a trade-off between all these agents. If we are going to decrease the anticoagulant or to minimize the dose of anticoagulant, such as warfarin in this case, we may have increased the risk of thromboembolism and stroke. If we decrease the antiplatelet agents, these patients should be on DAPT. So if we go with single agents, we will have increased risk of stent thrombosis, which in many cases is a fatal event. If we go with the 3 anti-thrombotic agents, definitely you will increase the risk of bleeding. In this particular case, we should make a very delicate balance regarding the risk of ischemia and the risk of thromboembolism related to atrial fibrillation and the risk of bleeding. And here I want to share some opinion with Dr. Ahmed Bendari, how to assess the risk of thromboembolism, how to assess the risk of bleeding, and how to assess the risk of ischemia in this particular patient.
Yes. Thank you, Dr. Karim, for these opening questions. These are the main topics which we are going to discuss step by step throughout the next slides. Let's start by asking the audience a simple question about the case and her clinical data, which has been recently presented. Which P2Y12 inhibitor do you prefer for this patient? Remember, she underwent an uncomplicated PCI to a proximal focal LAD stenosis with normal other coronaries, with non-paroxysmal AF, diabetic hypertensive, and history of right hemiparesis. Do you prefer ticagrelor or clopidogrel or prasugrel? I leave the slide for about 30 seconds for the audience to vote, and then we will come to an answer and explanation for this answer. So now we have all voting is going to clopidogrel. We have about 15 seconds again. YouTube audience also are going to clopidogrel. Okay, it seems that the answer 100% is going to clopidogrel, and actually this is right. Okay, but why clopidogrel? If we look to the 2019 European guidelines for diagnosis and managing patients with chronic coronary syndrome, we will find a clear statement that the use of ticagrelor and prasugrel, which are more potent antiplatelets that invite more risk of bleeding, is not recommended as part of triple antithrombotic therapy in patients combined with aspirin and oral anticoagulants. This is because ticagrelor and clopidogrel are potent agents, and so they are more potent, of course, than clopidogrel, but we are using here triple antithrombotic, P2Y12, oral anticoagulant, and aspirin. So if you use a more potent antiplatelet P2Y12, you are inviting more bleeding risk. Moreover, and this is very important, about 90% of patients enrolled into clinical trials that have evaluated the triple therapy we are discussing today were given clopidogrel. So if you are going to extrapolate or translate the evidence from the clinical trials to the real life, you should apply what has been done in the clinical trials. In the clinical trials, most patients, in some trials, more than 90% of patients were given clopidogrel. So clopidogrel here tipped the balance that Dr. Karim Saeed just mentioned, the delicate balance between not sacrificing the ischemic benefit and at the same time not hazardously increasing the bleeding risk. Okay, let's go directly to the second question. For how long do you wish to continue triple therapy in this patient? Aspirin, clopidogrel, and the oral anticoagulant. 1 month, or 6 months, or 12 months, or 18 months. I'll also leave the slide for about 30 seconds for the audience to have voting. We have an equipoise, dear colleagues. Some audience are going to A, and some other colleagues are going to 6 months, which is the answer number B. Number B. Dr. Karim Mahmoud voted for B. Dr. Zahran, Dr. Abdurrahman Gamal voted for 1. Welcome, Dr. Hatem Sukari. He voted for 6 months. Could we have the response from the audience in the YouTube channel? The majority of YouTube channel audience went to A. Okay, and actually here there is no absolutely correct answer and no absolutely wrong answer, but it seems the most correct answer is A. We should give triple therapy in this patient for 1 month. And this requires a little bit explanation through this slide, which I will stand for a few minutes to explain. If we look at this diagram, which is obtained from the most recent 2019 European guidelines for managing chronic coronary syndrome, this diagram illustrates how to manage the issue of triple antithrombotics in patients who have recently undergone PCI and are indicated also for oral anticoagulants. The first question that should be asked, am I concerned with the ischemic risk or am I concerned with the bleeding risk? The second question is, how could you assess the ischemic risk, and at the same time, how could you assess the bleeding risk? Increased ischemic risk, if we look at the bottom of the diagram, is defined as patients with acute clinical presentation. Our patients, if you remember, has a chronic coronary syndrome. She has not undergone PCI in acute setting. The second issue that enhances the risk of future myocardial infarction and enhances the ischemic risk is the anatomical and procedural features. Say, for example, bifurcation PCI, long stents, complex lesions calcified, or highly thrombotic lesions with high thrombotic burden. And this was not the case. If you remember, she went uncomplicated PCI to a focal, I'll say it again, a focal lesion with a stent which is not long, 3.18 millimeter, and the PCI again was non-complicated. So it seems that our patient, we are not a little bit concerned about her ischemic risk and future risk of myocardial infarction. On the other hand, if you are going to assess the bleeding risk, you are opted to use either the Has-Bled score or the APC score. The more famous one is the Has-Bled score. Let's apply the Has-Bled score to our patient. Has-Bled score in our patient, as we see, is 3. She is hypertensive, she has an old stroke, and she has, as we said, poor target time in therapeutic range or poor TTR. So she is at high risk of future bleeding. Intuitively speaking, our patients, in this patient particularly, I am concerned a little bit more about the bleeding risk. The bleeding risk is prevailing here. So I am elected to either give clopidogrel and oral anticoagulant from the start. This means from time 0. So I can omit or drop aspirin very shortly after PCI. Or I can give aspirin, clopidogrel, and oral anticoagulant for a period of 4 weeks or 1 month, and then after 1 month, give dual therapy in the form of clopidogrel, oral anticoagulant, or aspirin and oral anticoagulant. And this takes us to a new concept that has been introduced into the guidelines. Before speaking about this concept, I leave the stage now for a few minutes to my colleague, Dr. Karim Saeed, to discuss what's being done in this patient.
Thank you, Ahmed. Now we are in a very critical moment. We have to choose a duration. And also we have to choose a combination of antithrombotic therapy. First, to start, we do not have evidence that can guide us strictly about the duration. It is very difficult to make a unifying fixed principle that we can follow. But we have some guidance. When we want to estimate the duration and the combination of antithrombotic therapy, we have to estimate, as Dr. Bendari said, one, the ischemic risk. And this patient apparently does not have increased ischemic risk if we are going to adopt the feature related to the procedure or the anatomy. However, the presence of a stent and an proximal LED lesion, if this stent got thrombosed due to inadequate antiplatelet therapy, the infarction and the outcome will not be tolerated. So the risk regarding the ischemia may be not this low. The second issue is related to the risk of thromboembolism, and this is very important. This is related to the atrial fibrillation. How to assess the risk of thromboembolism in patients with atrial fibrillation? First, if this is a valvular atrial fibrillation, the risk is very high. And this patient is not having a valvular atrial fibrillation. She has a non-valvular atrial fibrillation. So how to assess the thromboembolic risk in a patient with non-valvular atrial fibrillation? We will use a CHA2DS2-VASc score. And what is the CHA2DS2-VASc score in this patient? She is a hypertensive, she is diabetic, she got cerebrovascular accident, and she has a vascular disease. So she has 5, she scores 5. So she has a very high risk for thromboembolism. So the oral anticoagulant should be optimal in this patient. And now to the final and the more important issue, the risk of bleeding in this patient. We will use the Has-Bled. What is the Has-Bled score in this patient? Here we may differ, because if we are going to adopt the hypertension, the Has-Bled define hypertension by systolic blood pressure more than 160. And this patient has a well-controlled blood pressure. Actually, the labile INR, which is another component in Has-Bled, is not going to have a valid impact if we are going to use a new oral anticoagulant. So actually, the Has-Plate score may be just only related to the use of additional antiplatelet in addition to the oral anticoagulant and the presence of cerebrovascular accident before. So she may not reach the score of 3. This is a point. The second point related to the duration. As Dr. Bendari said, this is the recommendation of the European Society of Cardiology. However, I want to grasp your attention to another document published by the North America Consensus, published in 2018. Now, the default strategy by this document is to give the triple antithrombotic therapy only during hospitalization. Let us say only for 1 week. And this was discussed by Dr. Ahmed Bendari, but this was given as an alternative option. However, by the American consensus, this is the default, to give the triple antithrombotic therapy for just 1 week. Then we can go by double therapy, that is oral anticoagulant plus single antiplatelet therapy for up to 12 months. Then after 12 months, we can go by oral anticoagulant. However, we have many alternative choices offered by the European and also offered by the American guidelines. We can go for 1 month if the ischemic risk is higher. We can go for 6 months, triple antithrombotic therapy, triple for 6 months in case of acute coronary syndrome and high risk ischemia in presence of low risk of bleeding. So the choice of duration is very variable. And it is dynamic. This is very important. Yes. It is a dynamic. Now we may have a patient who have a low risk, then he got bleeding. So now he is a higher risk.
Yes. Thank you, Dr. Karim.
We may have a patient with we may have a patient with a Has-Plate score 3 or 4, but now we got his blood pressure controlled. His renal impairment improved. So he is now at a lower risk.
Yeah,
so it is a very dynamic target. We should evaluate it case by case. So in this particular patient, if we are going to give the triple antithrombotic therapy just for 1 week, it is okay. 1 month, it is okay. 6 months, it is very long and the risk of bleeding is very high. So we should not go for this option. Okay, we can move on.
Thank you, Dr. Karim. Again, we would like to highlight that the answer for this particular question is not like a black and white answer. The issue is dynamic and is more or less left at the bottom line to the individual clinical judgment, which has no alternative in the clinical practice. We put forth this question to highlight this.
Ahmed, another point I want to illustrate, and this may be a tricky one. What is the CHA2DS2-VASc score value that we can go when we are going to use the antithrombotic therapy in patients who have a PCI? It is not the 1, it is 2 or more.
The cutoff level, you mean, Dr. Karim?
Other steps. Yes, if we are going to discuss a patient's atrial fibrillation without indication for depth and PCI, all we know, we go with warfarin or oral anticoagulant if the CHA2DS2-VASc is 2
or more.
This is class high 2. If it is 1 risk factor, it is class 2B. This is without indication for PCI. But now the guidelines give a CHA2DS2-VASc 2, only 2 or more, regardless male or female, If we are going to combine the depth with the oral anticoagulant, that is to say, if we are going to have a male patients without other risk factor apart from the coronary artery disease, which is a vascular disease, we can omit the use of oral anticoagulant because HCHAS-VASc is not 2, which is the lower threshold to start oral anticoagulant in a patient taking DACT.
That's very good piece of
very
information.
tricky point in the guideline.
This is a very good piece of information.
Thanks.
Actually, we put forth the previous question to highlight a new concept that has been introduced to the most recent guidelines, which is the early cessation of aspirin. And early here means less than 1 week. If you read with me, after uncomplicated PCI, like our case, early cessation of aspirin within less than 1 week, and continuation of dual therapy in the form of oral anticoagulant and clopidogrel should be considered, but when? If the ischemic risk permits. In other words, if the risk of stent thrombosis is low, or if concerns over increased bleeding risk prevails, such as the case in our patient. And this is irrespective to the type of the stent, whether the patient has underwent PCI with bare metal stents or even with drug-eluting stents. So here, you could give triple therapy for just 1 week and then drop aspirin and you go on with oral anticoagulant and clopidogrel. Okay, let's move directly to the third question that opens the discussion, or in other words, that deepens the discussion. The best oral anticoagulant for this patient is, you should keep warfarin as it is, no problem. The patient is doing very well on warfarin. Okay, you could manipulate the INR in other ways. Or you should give rivaroxaban 2.5 milligram twice daily. Or you go to apixaban 2.5 milligram twice daily. Or you go for rivaroxaban 15 milligram once daily. I leave the slide for about 30 seconds for the audience to have voting, and then we will move on. Some answers are going to apixaban 2.5 milligram twice daily. Other answers are going to rivaroxaban 50 milligram once daily, and the YouTube channel, mostly the majority went to number D, rivaroxaban 50 milligram once daily. So it seems that the majority of the answers went to D, and actually D is the correct answer. We will also stop here, and I'd like, before I go on, to hear some comments from Dr. Karim.
Okay. In this particular case, Ahmed, you gave the choice of Marivan versus the new oral anticoagulant. And among the new oral anticoagulant, you chose rivaroxaban in this particular dose of 15, and the vascular dose, which is 2.5, which is a small dose, and the small dose of apixaban. For myself, I want to discuss the issue of warfarin. Do we have specific indication for the use of warfarin in a patient with atrial fibrillation who underwent PCI? The answer is yes. We have some particular situations. This include, one, of course, patients with valvular atrial fibrillation. DWAC has no role in patients with valvular atrial fibrillation, those with prosthetic valve or those with moderate to severe mitral stenosis. The second group of patients are those patients with impaired kidney function, with eGFR less than, let's say, 15. There is no role for DWAC in those type of patients. The third, some authors and some guidelines suggests that if we have a patient who is already on Marivan, which is very well controlled, and the INR within the therapeutic range, the majority of measurements, and there were no complications, we can continue on Marivan. However, this suggestion is shaky because now we have evidence that WAC is superior to warfarin and in some patients in terms of mortality. However, we may consider this option when the availability of DWAC is not high, is not present. This is regarding the warfarin. Regarding the rivaroxaban, I have a comment, but I will not give it now, but we should take into consideration that rivaroxaban can be given either in 15 milligram or 20 milligram when we combined this agent with oral anticoagulant. When to choose the 15 and when to choose the 20, and we have evidence that favors the use of one of those doses. This will be discussed later. I will stop here and we will hear from Dr. Ahmed, then we may have some comment later on.
Okay, thank you, Dr. Karim. Actually, the correct answer for this question is rivaroxaban 15 milligram once daily. And this is because when using the oral anticoagulants for stroke prevention in patients with atrial fibrillation, and at the same time, the patient has undergone PCI and in need of some form of antiplatelets, either aspirin or B2Y12, it's recommended if you are going to use new oral anticoagulants, which are now given, as you said, Dr. Karim, preference over warfarin, you should use the dose prescribed in the clinical trials for stroke prevention in patients with atrial fibrillation. In other words, if you are going to use epixaban, you should use the full dose, 5 milligram twice daily. You should only go for the reduced dose, which is 2.5 milligram twice daily, if the patient has 2 or more of the following 3 factors. Number 1, the body weight is less than 60 kilograms, the creatinine is high, or if the age is more than or equal to 8 years old, which is not the case here. So you are here opted to choose epixaban 5 milligram twice daily. It was not among the answers. Dabigatran 150 milligram twice daily, edoxaban 60 milligram once daily. They are not widely available in Egypt. Or you should go to rivaroxaban 20 milligram once daily. And here there is a very tricky point. If risk of bleeding is prevailing over concerns of the stent thrombosis or ischemic stroke, you should think about reducing the dose of rivaroxaban from 20 milligram once daily to 15 milligram once daily. And here, the risk of bleeding, as we have shown recently, is prevailing a little bit more than the risk of ischemia or the risk of future stent thrombosis. So it's recommended, and we should consider thinking about reduction the dose of rivaroxaban from 20 milligrams to 15 milligrams. This is, as we see, class 2A level of evidence B. Okay, the problem when managing patients who have recently undergone PCI and at the same time have AF is that you cannot prevent all the 3 effectively. To prevent the stroke, you are of course in need of oral anticoagulants. To prevent the risk of stent thrombosis, you are of course in need of double antiplatelets or DABT. Combination of DABT and oral anticoagulants will for sure increase the major bleeding risk. And the picture becomes as this video. I leave this video for just half a minute to appreciate how it is difficult to tip the balance in these cases. I think you have appreciated it all. If you are going to prevent the stroke and prevent stent thrombosis, you are going to increase the bleeding. And if you are going to prevent the bleeding, you are going to sacrifice the stroke or stent thrombosis. It's a very complex decision. I think it's clear now. Okay. If we look to the triple therapy, and how much the triple therapy is providing benefit and risk, especially to elderly patients who have recently went through acute myocardial infarction and at the same time have atrial fibrillation. According to this important paper published in JACC in 2015, we will see that triple therapy does not provide much protection against the future death, MI, and stroke. As we see here, the confidence interval is crossing 1, but at the same time, there was a significant, more than 60% relative hazard increase in the risk of major bleeding when we are giving triple therapy, especially to elderly who have MI and atrial fibrillation. Okay, but what about the protection against ischemic stroke and the increased risk of intracranial hemorrhage? Triple therapy, of course, provide a benefit in reduction of ischemic stroke, but as you see, the benefit is not that large. The upper bound of the confidence interval here is touching 1, but at the same time, triple therapy more than double the risk of intracranial hemorrhage in those patients. If we put all this together, you will think and you will realize that triple therapy, okay, it might provide benefit in terms of reduction of ischemic stroke, but it for sure doubles the risk of intracranial hemorrhage and significantly causes more than 60% increased risk in major bleeding. The picture is clear now. When giving triple therapy to a patient, is increasing his or her risk of bleeding without providing that much benefit you are expecting. But why to drop aspirin? Actually, there have been a lot of talk recently about aspirin-free strategies in cardiovascular disease. This is due to 3 factors. The factor number 1 is that aspirin, of course, increases the bleeding risk, especially the GIT bleeding, as we see. The second is that we have, through the recent years, many novel antiplatelets and antithrombotics that could translate the relative benefits of aspirin, which was the only player in the field, into now a smaller absolute benefits. And there have been an emerging concept called dual pathway inhibition. This means, as you say, remembering from the basic physiology and pathology, thrombosis is a fibrin network entangling blood cells, including activated platelets. To prevent this fibrin network from formation, you are in need of oral anticoagulants. And the new oral anticoagulants, whether direct thrombin inhibitors or direct activated factor 10 inhibitors, inhibit this pathway that finally leads to formation of the active fibrin. But at the same time, active factor 10 is required for activation of the platelets. So you are in one way or another inhibiting the platelets. At the same time, when you are inhibiting the coagulation pathway, this have given rise to this emerging concept, the dual pathway inhibition, which is the synergistic action between oral anticoagulants and antiplatelet therapy. The first that I'd like to call nail in the coffin of the triple therapy was the WOEST trial. The WOEST trial was presented for the first time in 2012. This trial enrolled patients on oral anticoagulant for whatever reason who have underwent recently PCI and randomized them to receive either clopidogrel alone or clopidogrel in combination with aspirin 80 milligram. The primary endpoint for this trial, as we see, was safety endpoint, any bleeding within 1 year. And we could easily appreciate from this figure that the primary endpoint were significantly better in patients who received clopidogrel alone in combination with oral anticoagulants compared to patients receiving triple therapy. The p-value was less than 0.001. The authors in this trial concluded that among patients with oral anticoagulants who have undergone PCI, the use of clopidogrel alone compared with aspirin plus clopidogrel reduced significantly the frequency of bleeding events without sacrificing the ischemic benefit. In other words, without an increase in adverse untoward ischemic events. But why to prefer new oral anticoagulants over vitamin K antagonist in this particular patient? This table summarizes it all. The new oral anticoagulants have rapid onset of action. They have fixed dosings that does not require frequent monitoring. They have nearly no food interactions, very few drug-drug interactions. They, again, do not require frequent monitoring, short elimination of lives, not 2 days or 3 days or more like warfarin. All these have translated into a better patient convenience and a more widespread adoption from the patient and the physician perspective. The rivaroxaban was the first new oral anticoagulant to provide data in this complex subset of patients. I mean patients who have atrial fibrillation in need of anticoagulants and who have underwent PCI. This was an open-label randomized trial. They took more than 2,000 patients and randomized them 1-1-1 into rivaroxaban 15 milligram once daily plus a single antiplatelet, which was most of the time clopidogrel. The second arm received rivaroxaban 2.5 milligram twice daily plus double antiplatelets. The third arm was a conventional arm who have received vitamin K antagonists with INR range 2 to 3 plus double antiplatelets and followed them for a mean of 12 months. Again, those patients were paroxysmal, persistent, or permanent non-valvular atrial fibrillation undergoing PCI with stent implantation. What the authors showed in this important randomized control trial, the Pioneer AF-PCI, that both rivaroxaban-based strategies were associated with significantly better safety, and safety here means TMI major or TMI minor bleeding or any bleeding requiring medical attention. The number needed to treat in one arm was just 12 and the other arm was 11. Remember, the Pioneer AF-PCI trial was powered only for the safety outcome. It was not powered for the clinical outcome, despite the data that we will present soon that the clinical efficacy outcome was not different across these three major arms. And this is the slide. When comparing the efficacy between the three arms, the rivaroxaban-based strategies and the warfarin conventional-based strategy, in terms of cardiovascular death, MI, or stroke, there was no significant difference, but a caveat here is that this trial, again, was not powered for detection of difference across groups through this clinical outcome. I leave the stage now for my colleague, Dr. Karim Saeed, who will wrap up this complex area in few minutes, and then we will go on to other trials.
Thank you again, Ahmed. Now we are going to discuss a challenging, more controversial issue presented by the WOEST and the Pioneer study. The first point, as Ahmed said, the dose of rivaroxaban in the Pioneer study was 15 milligram, given with P2Y12 inhibitor. And the study showed a positive outcome, decreased risk of bleeding without increased risk of ischemic event. So we have evidence now to use a 15 milligram dose of rivaroxaban when we are going to use, in addition, single or dual antiplatelet therapy. It looks easy. However, it is not this easy, because as Dr. Ahmed said, and as Dr. Karim Mahmoud have stated in the chat, this study was not powered enough for the risk of stroke. So we do not have evidence that this dose of rivaroxaban, 15 milligram, is associated with decreased risk of stroke. And this gives explanation why the European guidelines till now still recommend the 20 milligram dose of rivaroxaban when it is combined with the DAT. However, the American guidelines, the AHA guidelines, in the atrial fibrillation management guidelines published in 2019, adopted the 15 milligram dose of rivaroxaban. So we have here a conflict, and this is expected in this very infantile field for the management of patients using newer antithrombotic therapy. This is a point. The second point, if we consider the pioneer study, it compared DWAC, here it is rivaroxaban, using P2Y12 inhibitors in different doses versus warfarin plus aspirin plus clopidogrel. But this study missed another important strategy. What about warfarin plus clopidogrel? This study did not compare rivaroxaban plus clopidogrel versus warfarin plus clopidogrel. And why it is important? Because in the WOEST study, we do have evidence that warfarin plus clopidogrel is associated with decreased risk of bleeding. And this strategy was omitted in all new oral anticoagulant trials, the Pioneer and the Augustus. Still, this is an unanswered question. And why it is important to have this arm, warfarin plus clopidogrel? Because we have a group of patients who do have benefit from this combination. I mean patients with prosthesis, not necessarily with atrial fibrillation. And remember that in the WOEST study, it included patients with prosthesis, not necessarily with atrial fibrillation. The inclusion criteria was patients on anticoagulant therapy, either due to atrial fibrillation indication or prosthesis. So we are missing this important indication, warfarin plus clopidogrel, especially in our populations who may not easily access the option of the more expensive new oral anticoagulant. Thank you, Ahmed, for letting me discuss this issue, and now we can move on.
Dr. Karim, I'm terribly sorry for the interruption, but we have an unanswered question from the YouTube. One of them is if there is any modification of the aspirin and clopidogrel doses in triple therapy or not.
I got this question and I intended to give the answer later on when we sum up at the end of lecture.
Okay. The second question is the clinical status of the patient, especially the comorbidities like anemia, malignancy, renal failure. Does this affect the management of triple therapy or not?
Okay, I will give my answer, then we can hear Dr. Ahmed answer. This is a very heterogeneous group of patients. You are talking about malignancy, you are talking about CKD. Let us, for example, discuss the CKD. Patients with CKD at increased risk of 1, ischemia. Stentus thrombosis is higher in patients with CKD. 2, patients with CKD are at increased risk of thrombosis. Stentus thrombosis, I mean. Number 3, patients with CKD are at increased risk of thromboembolism. Despite the serum creatinine is not included in the CHAS-VASc score, but we have other scores, such as the ATRIA score and others, that include the serum creatinine among its risk predictor. And actually, CHAS-VASc, the SCCR at the end of the CHAS-VASc was intended to be related to serum creatinine, but the database was not full to answer this question. Anyway, so patients with CKD are at a higher risk for thrombosis of the stent, bleeding from the depth, and embolism and stroke due to atrial fibrillation. What to do in this patient with a higher risk of bleeding and at a higher risk of thrombosis? If this is my patients, I will go as such. I will give triple antithrombotic therapy for up to, not for, up to 1 month, and the minimum 1 week. First week went well, I will go for the second week, monitoring any risk of bleeding. Second week went well, I will go to the third week. Third week went well, I will go for 1 month, and that's the end. Any signal for increased harm, I will stop the triple and I will go to the double therapy. And for the double therapy, I have the option to go for 6 months only. If there is a higher risk of bleeding, then I can go for oral anticoagulant. Of course, in patients with CKD, I will use, if it is advanced CKD, I will use warfarin with repeated monitoring, keeping the INR toward 2. And if it is not, I will go for apixaban. I mean the AGVR more than 15 without 2 or among the 3 risk factors Dr. Bendari have said. I will use apixaban because of its reported data and safety profile among patients with CKD. This may summarize my answer for this question.
Okay, thank you. Thank you.
Actually, I agree with Dr. Karim that these are a heterogeneous group of patients. He have answered the first part about CKD patients. We would like to highlight the fact that most physicians still now go to warfarin as an oral anticoagulant of preference in this particular group of patients, despite the data encouraging now for in favor of apixaban, particularly in terms of malignancy. The data for new oral anticoagulants are encouraging. We have good data for rivaroxaban, edoxaban, and recently I think the Caravaggio trial have been reported. But a caveat here is that we should not use new oral anticoagulants in patients with atrial fibrillation and GIT malignancy because they have been reported to be associated with increased risk of GI bleeding. Okay. Let's now, for the sake of time, move to an important slide, which is a subgroup analysis from the Pioneer AF-PCI trial. This subgroup showed that the future rehospitalization due to cardiovascular reasons and the bleeding were both reduced when rivaroxaban is used compared to warfarin. And actually, this is intuitive when you are reducing the bleeding risk and when you are reducing the cardiovascular events. Of course, this will translate into a reduction of future rehospitalization. But again, we would highlight the fact that this trial was not powered to detect difference in hard clinical outcomes. Rapidly, I'll go through the ReDual PCI trial. Its design was a little bit similar to the Pioneer AF-PCI trial. They took 2,000 plus patients with AF who have underwent PCI and randomized them into 3 arms. The first arm is the full dose of dabigatran, 150 milligram twice daily, plus P2Y12 inhibitor, which was most of the time clopidogrel. The second arm was dabigatran, 110 milligram twice daily, plus P2Y12 inhibitor. And the third arm was the conventional arm, the warfarin with INR 2 to 3, plus 2 P2Y12 plus aspirin, and they followed them for a mean of 14 months. As expected, this trial provided a significant safety signal towards significant reduction of the first International Society of Thrombosis and Hemostasis major bleeding, or this is a new term, clinically relevant non-major bleeding. The difference was much more significant for the reduced dose of dabigatran as compared to the full dose of dabigatran, but both were significant in terms of the statistical concept of p-value. I'll not go rapidly or deeply, excuse me, in this trial because actually dabigatran is not widely available in Egypt till the moment, but here this is a very, very, very important slide. The ReDual PCI trial that I have just mentioned and the Pioneer AF-PCI trial have left us with a very tricky unanswered question. These both trials compare dual therapy in the form of new oral anticoagulant and B2Y12 inhibitor versus the triple therapy, warfarin, B2Y12 inhibitor, and aspirin. Therefore, it is unclear whether the reduced bleeding risk observed in this both trial is the product of the drop of aspirin or is the product of the new oral anticoagulant itself as compared to warfarin. In other words, we do not know what's the secret, what is the key word here. Is it the dropping of aspirin that works, or is it the substitution of warfarin for due oral anticoagulant that works? In this case, statistically, you are in need of what we call a 2-by-2 trial. What I meant by 2-by-2, 2-by-2 is simply randomization at 2 levels. In other words, you first took those patients and randomized them between different coagulation strategies. Half of them will go to warfarin and half of them go to new oral anticoagulant. And then another level of randomization, randomize them between receiving aspirin and receiving placebo. And this was the key sweet point in the AUGUSTUS trial. In this trial, they randomized a large number of patients, more than 4,500 patients with atrial fibrillation who have recently underwent PCI or have an acute coronary syndrome. And this is a new category of patients to be enrolled in such trial. They randomized them between receiving epixaban 5 mg twice daily or reduced dose of epixaban in the 3 situations we just mentioned, or receiving a vitamin K antagonist with target INR 2 to 3. And then they took another, again, I'll say it again, another level of randomization. The group which went to epixaban were randomized to receive either aspirin or placebo. And the other group which went to VKA were randomized another time to receive aspirin or placebo. So we have here 4 unique groups. All groups received, all patients, or the 4,500 patients received the B2Y12 inhibitor. But a group of patients in addition received epixaban and aspirin, epixaban placebo, vitamin K antagonist aspirin, and vitamin K antagonist placebo. So we have here a 2 level of randomization yielding a 4 unique randomized group. The primary outcome here, similar to the redual PCI trial, was the International Society of Thrombosis and Hemostasis major bleeding or the clinically relevant non-major bleeding, and the secondary outcomes, of course, were the clinical hard outcomes such as death, hospitalization, and the ischemic events. I'll pause here because this is a very important statistical tricky point that would like to be clarified and reiterated by Dr. Karim Said.
Ahmed, please can you go and represent the results, then we can have some comment upon the results.
Okay, I'll display the results of the redual PCI. Okay, I got it. Okay.
Yes.
Okay. Let's look to the primary endpoint of the AUGUSTUS trial, which was the major bleeding or the clinically relevant non-major bleeding. If we compare the 2 major groups, the epixaban-based group and the VKA-based group, we will see a significant reduction in the primary endpoint, which was not only non-inferior, but epixaban-based strategies deemed to be significantly superior to the vitamin K antagonist-based strategies. But if we look to the other 2 groups, which are aspirin versus placebo, we will see, let me say again, a very significant, more than 80% increase in major bleeding in the group which received aspirin compared to the groups that received placebo. From these 2 slides, we could conclude that aspirin is looking to be the secret word. It's the culprit here, which adds a significantly higher risk of future clinically relevant non-major or even major bleeding, because aspirin here, as we see, was associated with more than 80% significant increase in bleeding. The number needed to hazard was just 14, but if we looked to the previous slide, the epixaban-based strategy was associated with significantly lesser hazard compared to vitamin K-associated based strategy. Another important point, if we put all these 4 randomized unique groups together, we will see that the group that received epixaban plus placebo was the least among the 4 groups to show an adverse outcome in terms of bleeding, and the group that received a vitamin K antagonist plus aspirin was the group that showed the highest risk of developing future major or clinically relevant non-major bleeding. The next 2 slides are very important. The question is, you said, Dr. Ahmed, that aspirin increases the bleeding risk, but does it provide any benefit in terms of the future hospitalization or mortality in those patients? Let's answer by the next 2 or 3 slides. If we compared again the AUGUSTUS trial, the 2 groups that received epixaban versus warfarin, we will see that epixaban was associated with significantly, there was actually a trend towards lesser future mortality and hospitalization. But when we compared the 2 groups, the group that received aspirin versus the group that received placebo, there was no significant difference. In other words, not only aspirin significantly increases the bleeding risk in those patients, but also it does not provide any benefit in terms of reduction of mortality and hospitalization. And this trial was the base for the first recommendation we mentioned in this presentation, that you could omit or drop aspirin very early after uncomplicated PCI if, and I will say it again, if the ischemic risk permits and the bleeding risk prevails over the ischemic risk. If we put all these trials together in a recent landmark meta-analysis published just 1 month ago in the Annals of Internal Medicine, they put all the 4 trials together, comprising more than 8,000 patients. They compared the triple versus dual therapy after BCI with the stent implantation in patients with atrial fibrillation. The main core finding from this meta-analysis is that dual therapy compared with triple therapy was associated with a significant reduction in major bleeding without any significant increase in the untoward or major adverse ischemic events. Before I conclude, I would like to hear the clarifying and the iterating comments from my colleague, Professor Karim Said.
شكرا يا أحمد. Thank you, Ahmed. I want to give some points related to the epixaban, which is tested in the AUGUSTUS trial. This trial recruited a high-risk patients because, as you mentioned, Ahmed, recruited patients with acute coronary syndrome. So those are patients are at increased risk for ischemia during the first year, pre-infarction. Second, this is the only trial that included patients with prior stroke, like your patients in your case scenario. The Pioneer excluded patients with stroke. So it also included patients at increased risk for thromboembolism due to atrial fibrillation. And despite these high risk features in terms of stroke and in terms of ischemia, the drug proved safety profile with decreased risk of bleeding and decreased or non-increased risk for ischemic event. This is a point. The other point is related to the risk of stent thrombosis.
Yes.
In this trial, omitting aspirin was associated with twofold increase for the risk of stent thrombosis numerically. And the study was not empowered enough to analyze or to conclude about the impact of omitting aspirin on the risk of stent thrombosis. So till now, we do not have this strong evidence in those high-risk patients. Now we are talking about high-risk patients, that omitting aspirin is definitely safe in terms of stent thrombosis. The third point, now we have evidence. In apixaban, we can use the 5 milligram dose. This is the standard, classic, recommended dose for apixaban when combined with antiplatelet therapy. It is approved on contrast to the 15 versus 20 milligram dose for the rivaroxaban. And this may answer a question given by a colleague who asked about when to use the 20 milligram dose of rivaroxaban. If we are go by the European guidelines, as shown by Dr. Ahmed, okay, this will be given for patients at low risk of bleeding. Okay, and 15 yes, for the patients at a high risk of bleeding. Going by the American guidelines, HA, the 15 milligram is the recommended dose. So till now, when we consider DAPT or SAPT, apixaban or rivaroxaban, we should know the inclusion and the exclusion criteria of each trial, and to pick up the type of patients based upon the features of the corresponding trial. Thank you.
Thank you, Dr. Karim. Now we come to an end, and I'd like to highlight very important 4 take-home messages for my colleagues and friends. First, aspirin and clopidogrel should be given perioperatively. Perioperatively means before and the short time after the PCI. I mean by this short time, at least for 1 week. So as I said, this should be given perioperatively in patients with an indication for oral anticoagulant undergoing PCI. This is number 1. You cannot leave aspirin before or the short time, at least 1 week after PCI. Even in the AUGUSTUS trial, aspirin was stopped not immediately after PCI, but immediate 3 to 5 days after PCI. The second point is that clopidogrel, but not ticagrelor or prasugrel, is the P2Y12 inhibitor to be used in triple therapy. This is because clopidogrel tips the balance between the ischemic benefit and the increased bleeding risk. Moreover, more than 90% of patients enrolled in trials evaluating triple therapy were given clopidogrel, but not ticagrelor or prasugrel. The third point is that you should, and we should try to shorten the duration of triple therapy to a minimum in order to decrease the bleeding risk, with consideration again given to early cessation of aspirin if, and I will say it again and again, the ischemic risk permits and the bleeding risk prevails over the condition. Finally, new oral anticoagulants now are preferred over vitamin K antagonists in patients on triple therapy, considering all these trials that I have mentioned, but remember, they should be used by the doses tested in the clinical trials for stroke prevention in patients with atrial fibrillation. The only exception is that you can go in rivaroxaban from 20 milligrams to 15 milligrams if you are concerned more with the bleeding risk. But if the ischemic risk prevails, you should give rivaroxaban 20 milligrams, despite the fact that the dose of rivaroxaban that have been tested in the Pioneer AF-PCI trial was just 15 milligrams. And finally, I'd like to thank you all for listening. It was really a pleasure to join such a marvelous group of colleagues, and I hope we will meet together soon in future meetings, inshallah.
Thank you so much, Dr. Ahmed Bindari. Dr. Karim, would you like to say something?
Yes, first of all, I would like to thank Dr. Ahmed for this one effort to brilliant summarization for this difficult subject.
Thank you, Dr. Karim.
And to select the pertinent, important, practical, clinical points among the sea and the ocean of many irrelevant data when we consider this controversial issue. I got some questions from our colleagues in this interface and from the YouTube, and I want to share our opinions. If we have time, Karim?
We do. Please do, Dr. Karim, please.
Okay. We have some questions. I will go systematically. The first question, one of our colleagues asked about, does the size of stroke, this patient had stroke, does the size of stroke had any impact in relation to the duration and the type of antithrombotic therapy in this patient? What do you think, Dr. Ahmed?
I don't think that the area of stroke has an impact on the decision to give or not to give anticoagulation, but it could affect the time of initiation of anticoagulation after stroke onset. If we have a large area of stroke, say for example MCA, middle cerebral artery, some neurological colleagues would like to wait for 1 week or 2 weeks before initiating anticoagulation for fear of hemorrhagic transformation. But once stroke, even if TIA, I think it's given the same weight in CHA2DS2-VASc score compared to overt stroke. It doesn't affect again the decision whether to give or not, but it affects the decision of timing of initiation of anticoagulation. This is, and I'm speaking about the area of the size of the stroke.
I totally agree with you, Dr. Ahmed. A next question, the dose of aspirin. If we are going to give an aspirin to one of our patients, what is the recommended dose?
Actually, most of the trials gave aspirin in a dose ranging from 75 milligrams to 80 milligrams. However, if you went from 80 milligrams to 100 milligrams, there is no problem. But intuitively speaking, I'm giving a patient a triple therapy for at least a week or more than 1 week. If the ischemic risk is high, I would go for the least effective dose of aspirin prescribed in the guidelines, which is 75 milligrams once a day.
I agree with you. I will not exceed the 100 milligram dose. We have the 75, the 81, and the 100 milligram aspirin. And in this particular combination, definitely we should not forget the use of proton pump inhibitor. It is a must when we are going to give DAPT or triple antithrombotic therapy, to give one of the proton pump inhibitor systematically and routinely.
This is important.
In our, yes, this is important to start with. Once there is DAPT plus oral anticoagulant, even without oral anticoagulant, give a PPI. There is an interesting question here regarding the type of stent. Should we tailor the duration of antiplatelet therapy or the combination considering the type of stent? I will answer this question.
Okay.
Okay. If we go to the guidelines, we will not ever find a duration for the combination of antiplatelet therapy or the antithrombotic therapy emphasizing the type of the stent. This is very strange because now we have a flood of data. Many types of stent, Biofreedom, Leader, Synergy, many types of senior trial that at rest we can give a short duration of DAPT, let us say 1 month, when we obliged to do so. And despite this data, no guidelines ever considered the type of the stent when we tailor the duration of antiplatelet and the antithrombotic therapy. Why? For several reasons. I will take the Leader trial and other trials. We'll find that the inclusion criteria to define the risk of patients in terms of excess bleeding is very heterogeneous. And the majority were driven by age. by age, not by the concomitant use of dual antiplatelet therapy, excess risk of bleeding, perioperative non-cardiac surgery, GIT bleed. Yes, this was present. However, the main driven for the excess risk of bleeding necessitating a short duration of therapy in those patients was age. So we cannot extrapolate this piece of type of patients to our very high risk patients. This is a point. A second point, the risk of stent thrombosis. If you went to the LEADER and the Synergy and other trials, the risk of stent thrombosis in those trials is not low. Compared to other stents given in a lower risk of patients. So the message and the bottom line here, do not tailor the type and the duration of antiplatelet therapy plus oral anticoagulant, considering the type of the stent. Use a very good second or third generation stent, deploy it well, and that's all. This is my answer for the type of stent. Do you agree, Dr. Ahmed?
I totally agree. This is a comprehensive answer. The type of the stent should not have any reflection on the duration of triple therapy or even the choice of the agents. I think this is summarizing what you have said, Dr. Karim. Yes?
Other questions, the dose of clopidogrel?
The dose of clopidogrel was 75 milligram once daily. And yes, the patients were given the triple therapy in these trials not more than 3 days after PCI.
Okay, another question related to the timing of therapy in the AUGUSTUS trial, the apixaban.
Yes.
Within the protocol, within the PCI, the study regimen was started as soon as the parenteral anticoagulant was stopped. So it started within the hospital. Once the Clexane or unfractionated heparin stopped, we start the regimen, which is
actually in most of these trials, it was not allowed to delay the initiation of the study medications more than 120 hours, or in other words, 3 to 5 days after the PCI. If the patient passes this time, he's out.
Yes. We have many interesting questions, really. A question, I will go systematically, and if I missed a question, please send it again. What about if the patient has a history of cerebral hemorrhage instead of stroke? Would this affect your decision, Ahmed?
Again and again, it's a matter of time. The history of cerebral hemorrhage does not preclude any patient from being given antiplatelets or anticoagulants. It's okay, I agree, it's being incorporated into some risk scores for assessing the bleeding risk. However, if a lot of time has passed since patient developed cerebral hemorrhage, let's say more than 2 months, or even if the patient is in the hospital and about 1 week or 10 days have passed with a stationary course of cerebral hemorrhage, and the patient is not at a very high risk of rebleeding, this will not affect my decision to manipulate the triple therapy in this patient. However, I will try to keep the triple therapy in this patient to a minimum, and I will give consideration for stopping aspirin 1 week after PCI.
For myself, it is very difficult to give a straight unifying answer. Every patient has a cause and a profile for this cerebral hemorrhage. For example, if a patient had cerebral hemorrhage because of while he is on, let us say, DEPT, aspirin and Plavix, and this caused him a cerebral hemorrhage. Of course, if I'm going to start oral anticoagulant again when he developed atrial fibrillation, the risk is very high. I will not consider oral anticoagulant in this patient because he developed cerebral hemorrhage while receiving ADAPT. I will look for a mechanical occlusion of his left atrial appendage, for example.
Yes.
It is difficult to give a straightforward unifying answer for this very unanswered and untested type of patients. Another question, how to manage antithrombotic therapy in patients with acute coronary syndrome, underwent PCI, and this is the tricky part, has left ventricular thrombus. What do you think, Ahmed?
Yes, till now, left ventricular thrombus, we all agree that it requires an oral anticoagulant for resolution. But we do not have data till now confirming the efficacy and safety of new oral anticoagulants in such patients, despite the fact that a trial is ongoing. However, many case reports and many observational data, some of them have been recently published and press released. I think I read this in Medscape a few days ago, that the data are not favoring the safety and efficacy of new oral anticoagulants in this group of patients. So I will move to a VKA or warfarin-based strategy and then continue as we described.
I agree with you, Ahmed. Actually, you are referring to a paper published in the JAMA Cardiology about
yes, I think recently, one week ago or 2 weeks ago.
And in this study, it was non-randomized study that compared DWAC off-label use, and actually the title was off-label use of DWAC versus warfarin in patients with left ventricular thrombus. And the results were left ventricular, use of DWAC was associated with increased risk of cerebral and systemic embolization.
Yes.
And according to this paper, it is not recommended to use this type of new oral anticoagulant among patients with left ventricular thrombus. However, we have another trial published before this that found no difference. And in this new JAMA Cardiology paper, when we look to the separation of the two curves, stroke and embolization, warfarin versus DWAC, we will find a very interesting findings. The two curves started to separate very late, not early, and we know that we should give anticoagulant only for 3 to 6 months for left ventricular thrombus. And the impact of DWAC versus warfarin should be compared only for the 6 months, during which we should have an effect. However, the difference was shown afterward. So we do not have answer. And I agree with you, for those type of patients, we should use only, till now, warfarin. Another question, none of this trial powered for efficacy. Any data regarding Entrust study with the edoxapan?
I think the Entrust trial was also not powered for efficacy. I do not have currently the full data. The edoxapan is not available in Egypt, so I was not so interested to look to dig deeply into the data. If you have dived deeply into the data of Entrust trial, Dr. Karim, you can answer this question.
There was no difference. There was no difference in bleeding, so it looks not positive as rivaroxapan and apixapan till now in this dose. What is the management of major bleeding with triple therapy, and which agent to stop in the context of significant or major bleeding?
That's also a very difficult question, again, to give a one or a single unifying answer to all subset of patients. If the bleeding is life-threatening, here you should weigh the risk-benefit. Some cases require withholding all antithrombotics till the source of bleeding is managed. However, in patients with major but non-life-threatening bleeding, I will look to the timing of PCI. If there were more than 3 months from PCI, I will temporarily in patients with major bleeding, stop antiplatelets, and maybe I will maintain the patients on oral anticoagulants. On the other hand, if the patient has recently underwent PCI, the risk here of stent thrombosis is higher than the risk of stroke, so I will stop the oral anticoagulants. But all over, in case of major life-threatening bleeding, you should stop all antithrombotics, including even the oral anticoagulants, till you resuscitate the patient and manage the source of bleeding. I'd like to hear your answer, Dr. Karim.
Again, this is we have very complex multiple scenarios, but the rule, if we are going to stop the antiplatelet, if it is a bare metal stent, we can stop all antiplatelet after a month. This is the American guidelines. And if it is a drug-eluting stent, if it is inserted within a setting of acute coronary syndrome, we can do it after 3 months, 6 months, maybe 3 months. And if it was implanted within a setting of stable coronary artery disease, we can stop after 3 months, maybe 1 month. Before this, the risk of stent thrombosis is not low. For the oral anticoagulant, if the cause of bleeding was related to the oral anticoagulant, we have different multiple algorithms to manage: one, the bleeding, and two, to choose what type of anticoagulant to go. If it is warfarin, what to do. If it is a dual DUAC, what to do. We have many algorithms. And if the bleeding is necessitating surgery, what to do regarding the bridging. It is very difficult question with many probability, with many answers based upon the situations, and it will not satisfy
all scenarios.
Yes. What is the duration of vitamin K antagonist in this case?
I think Dr. Ahmed Mohsin means the duration in case of LV thrombus.
LV thrombus, okay. As you know, it is between 3 to 6 months. However, it is not a black and white rule. We should follow the thrombus. Follow the thrombus in terms of the size, in the term of the mobility, in the term of the echogenicity, in the term of the presence or absence of daughter thrombi. If all of these are favoring, the thrombus is decreasing the size, becomes more echogenic, becomes fixed, no daughter thrombi, then we can stop the anticoagulant. If it is not, we'll continue the anticoagulation. Or until the reason by the echo. No, we can stop once the thrombus is echogenic and fixed and not increasing the size. Left ventricular thrombus, NOAC2 studies showed good results for rivaroxaban for 8 to 12 weeks with echo follow-up and the small trial. Yes, I mentioned that there was a prior study, but the most recent study did not show such favorable results. And now there is an ongoing study. Remember the use of DUAC with antiphospholipid syndrome. We had a positive data and we have a negative data, and now it is contraindicated to use DUAC in patients with antiphospholipid syndrome.
Until we have randomized data, we cannot recommend, I think, new oral anticoagulants in patients with LV thrombus. Here, I'd like to highlight the efforts of our colleagues in, I think, Alexandria, Dr. Abdullah Al-Maghrabi and Dr. Mahmoud Abdelnabi. They have registered in clinicaltrials.gov a randomized trial with a calculated sample size for this issue. And I think this trial will have a good impact on clinical practice if they followed the design accurately and properly.
And the last question, because we're asked to stop, but it is an important question because we didn't mention the term COVID in this presentation, which is very strange. So we should mention the term COVID. We are in the COVID era. So,
COVIDization.
yes. So we have a question: the choice of antiplatelet therapy during the COVID-19 pandemic. Do we have any insight? In short, there are many interactions. The safest drug, the safest antiplatelet to use is prasugrel. It doesn't have interaction with the different agents. Also, among the parenteral, you can use the heparin. It doesn't have interaction. Aspirin as well doesn't have interaction. However, apixaban does have some interaction, the same as ticagrelor and the same as warfarin. It has interactions. I think we come now to an end for this important, very interactive presentation. And I can hear from my colleague, Dr. Ahmed, and then Dr. Zahran, Dr. Karim, and Dr. Haitham.
Thank you, Professor Karim, for your insights. It was really nice and a pleasure to be with you and you all in this important session. I have no comments to conclude other than that I hope this to be repeated. I leave the microphone now to my colleagues, Dr. Zahran, Dr. Karim, Dr. Haitham, and others. تفضل Dr. Zahran.
Actually, I got on the private messaging from Dr. Haitham and Dr. Karim that they collected all the questions already answered by Dr. Karim Saeed. So I will conclude the session, but before I conclude, actually, first of all, this is one of the best, if not the best, not only webinar, but for me, my own self, this is me speaking from my own point of view. Interactive lectures from which for me I learn a lot of data in a very easy and smooth way. I did not feel bored. We've been working here for 1.5 hours, by the way. I'm not feeling bored at all. It's very smooth, and this goes to the high level of professionality from Professor Karim Saeed and Dr. Ahmed Bindari. It's not easy at all for everyone that's listening and watching us to perform this kind of work with this kind of interaction and this kind of harmony between two highly scientific profiles discussing a very, very, very complicated issue with lots and lots and lots of data in a very calm and easygoing way. You just feel the data slipping to your brain. You don't even need to digest or integrate anything. This is how actually it works at CEC. We choose the best profiles, and actually Egypt is very rich with its professors, and Professor Karim Saeed and Professor Ahmed Bindari are actually on board on this channel with their highly scientific profile. I'd like to wrap up the session. What we discussed today actually was what a wise doctor would do. A wise doctor would tailor the management per patient on patient-by-patient basis, because in 2020 we are lucky enough. 10 years ago we did not have NOACs in our hands. Now we have novel oral anticoagulants, and we have very good tools and powers to prevent the ischemic risk and reduce the ischemic burden. During the progress of science and during the progress of stents and during the innovation that happened in the tools and techniques of interventions and PCIs, also innovations happened in the terms of antiplatelets, antithrombotics, and anticoagulants. So actually you have lots of guns on the market, you have lots of tools, but you need to choose which tool for each patient. And as Professor Karim terminated his lecture commenting on the the numerical doubling of the stent thrombosis that happened with omitting the aspirin, and this is going to be a very important hot topic that will be addressed later on by any trial that needs to be empowered to tackle this important issue, because it looks like aspirin is going to be dropped out very easily from our practice, although we have been using it for nearly 100 years or more. So Actually, there is only one single issue that needs to be tackled, not by us, maybe by those that are presenting the science to the world. We have an aspect of patients, especially in Egypt, the mechanical valves patient. And those mechanical valves patients are stuck with vitamin K antagonist, and they will be using dual antiplatelets if they did a PCI. So maybe let's keep this hot question in mind. We will discuss it again. I am terminating the session now. I would like to thank very much Dr. Karim Mahmoud and Dr. Haitham Sulaiman for managing the YouTube elegantly. Dr. Ahmed Saeed for streaming this live and doing all the technical issues very easily. The live streaming on YouTube did not even cut for 1 second. Dr. Abdurrahman Gamal did a big effort with me in preparing this session actually, so thank you so much. Dr. Hatem Al-Sukkari, Ahmed Mohsen, Abdullah Al-Maghrabi, Sharif, Khalid Shams, Ahmed Gamal, everyone that attended with us. You are our team and you are our family and our platform. Finally, thank you so much, Professor Karim Saeed and Dr. Ahmed Bindari for sharing with us, and this is not our last meeting together. See you all well. Ramadan Kareem.
رمضان كريم.
السلام عليكم
تصبحوا على خير وعليكم السلام
وعليكم السلام.
تصبحوا على خير.